Good day, everyone. Welcome back to IVHEM 2020. We're now into session 4, where we'll be receiving more information about the status of the progress toward hepatitis elimination in a variety of countries and learning about tools that can help in national planning for hepatitis elimination. We'll start off with a presentation from Dr. Faisal Sultan from Pakistan, who's a special assistant to the Prime Minister on National Health Services, including providing the coordination for their national hepatitis elimination program. This will be a recorded presentation, and then we'll continue with the rest of the session. Thank you.
Hi, good morning and good afternoon. Greetings from Pakistan. I'm Faisal Sultan. I'm the special advisor to the Prime Minister on health. And in the next few minutes, I will try to tell you about hepatitis in Pakistan, in particular hepatitis C, and the coexistence and impact of COVID-19 in the present time. When we look back to 2008 and draw a trajectory, an extrapolation of where we might be in the future, it does look a little bit concerning. Back in 2008, the HCV infection prevalence was around 4.9%. And over the years, it has actually come up, and right here in the present time, in 2020, we think it is around 6.9%. If the present trend continues, we would reach a prevalence of 9.3% in the future in 2030. And back in 2080, when we had the second highest number of hepatitis C cases in the world after China. So there is no question that in Pakistan, hepatitis is a public health emergency. And we are committed to eliminate hepatitis by 2030. Now, as part and parcel of this program, we have had a Prime Minister's program which was put together for the elimination of hepatitis C infection. We have a fundamental goal and aim of eliminating hepatitis C by 2030. And this 10-year program has 2 phases. Phase 1 from 2020 to 2025, and the second phase from 25 onwards to 2030. So the main objective of phase 1 is to screen 50% of the eligible population using rapid tests. And this is for population over the age of 12. The second objective within phase 1 is to run an HCV PCR on all those that test positive on a rapid test. And then, of course, to treat all those that come out with a positive PCR for hepatitis C infection. There are additional or complementary objectives within phase 1, and one of them is to actually strengthen the supply side, the health system, with a focus on supply chain management and building human resource across the system. At the same time, to actually generate some demand of this, because without this, the program would not be a success, and this will require an effective and careful communication strategy. And then, of course, we do need to strengthen the information system, the monitoring abilities, and to evaluate the program progress. And then within phase 2, these activities would need to be replicated and to fill in any gaps that remain. So the global target, the overall target by 2030 is to make sure that 90% of all hepatitis C patients have been diagnosed, 90% of those eligible have been treated, and 90% of those treated are cured. So a 90-90-90 plan. The Prime Minister's program target, of course, in phase 1, as I mentioned, July 20 to 25, is to screen 50% of the population, which means a rapid test screening process for 69 million people. And we estimate that that would mean a PCR confirmation in about 5 million people, and then over 4 million people would require treatment. In the second phase, which will go on from 2025 onwards, you'd need another 102 million people to be screened. This is an ambitious program, but nevertheless, the nature of the problem is such that it does require ambition and boldness. So the intention and discussions of the program were to launch the program in early 2020. However, right in February, we had the first case of COVID reported in February. And of course, then maximum enforcement of the non-pharmaceutical intervention started by mid-March, and with a number of social distancing measures, all of which, of course, contributed to a stoppage or halt of this program. A lot of attention and money got diverted to the COVID-19 response, to ramp up testing, surveillance, the healthcare capacity, risk communication, creation of biosafety labs and PCR machines. So really the entire focus in terms of manpower, systems, and money got immediately and urgently shifted. So tens of thousands of healthcare staff were trained on infection prevention and control and disposal of infectious materials through the WeCare program. And as I mentioned, will mention in a bit, this also will pivot into an opportunity. So because of this, the program, including the hepatitis-related activities, were not prioritized, delaying the Prime Minister's Hep C program. But where are the opportunities? Both COVID-19 and hepatitis C are viral infections, which are confirmed using a nucleic acid method. And during COVID-19, the biosafety labs that were created, PCR machines that were added at a secondary and tertiary level into the health system, will actually play a significant role in helping us to pursue the hepatitis program. So on top of these PCR machines that were placed in, 400 gene expert machines are already available in the district headquarters hospitals. And these, of course, can also be used to deploy nucleic acid testing for hepatitis C, as they are now being done, as they're now being deployed to some extent for COVID. So there is an opportunity here. I think the urgent buildup of the health system that came into force during COVID will actually help in ensuring that the hepatitis program is also adequately powered. In addition to the simple deployment of machine and manpower, the other thing that is crucial in a program like this, of course, is coordination and cooperation. And so during COVID-19, what we saw was really an unprecedented level of coordination through the National Corona Operations Center. And really, it will serve as a blueprint for coming health challenges. And I feel that this learning that has been done ought not to be wasted and ought to be immediately deployed for other programs, not the least of which is hepatitis C, but then other things like polio and our expanded program on immunization and other infectious diseases. The other benefit out of this is that the mapping of existing resources, especially diagnostic, PCR, etc., has happened. So not only that they are there, we know where they are, and so their use would be made easier in the present circumstances. We also learned integration of the data. The data flows were fixed, and a backwards and outwards reporting to the provincial district levels. So a two-way communication between the provinces and the national system was ensured for COVID, and I think it'll go a long way in helping us bridge any gaps that exist for hepatitis. Of course, training and capacity building of the health workforce and on infection prevention and control is yet another facet that I think will go a long way, because a lot of hospitals really learned a more formal and more stringent way of infection control than what they were practicing earlier on. And on top, of course, as I mentioned earlier, on the demand side of things, the mass risk communication is important. And again, for COVID, we were able to deploy this using conventional and modern methods, all the way from cell phone messages, voice, call tone, dial tone messages, and social media, and so on. So I think that this COVID crisis, while it put a pause onto things, has also provided an opportunity and shown us a path as to how we can utilize this to control and conquer other diseases. So the challenges, of course, have been that multitasking in the health system of a major crisis is sometimes difficult. I think even in advanced and developed countries, this is a challenge. But for a developing country, I think this is certainly an issue. And of course, the other problem that has existed until now and may even exist in the future, if God forbid we have additional waves, is that the strict enforcement of NPIs and closures of outpatient services, of course, impact on other diseases, their care and prevention, which of course includes hepatitis. This also has led to issues where the global and domestic supply chain disruption has become and could potentially be another area where we would need to overcome a challenge. And so now we have almost a year's delay in the delay of the Prime Minister's program. But nevertheless, we feel that we currently have strong political commitment. There is complete buy-in from the provinces and within the national system and also within the public and decision makers that healthcare is a priority. And this commitment is required to make sure that we take care of the public, and especially in terms of prevention and control of epidemics and infectious diseases. And of course, hepatitis C is certainly an important infectious disease to sort out. Of course, as I mentioned earlier, a concerted effort to strengthen health systems and infrastructure and health services is there. In addition, use of logistic and supply chain management and management information systems with interfaces across the provinces down to the district and implementation level are also crucial, and many of these systems are now in place. We do need to, of course, build capacity of the health workforce on infection prevention and control, and to make sure that also has cross-cutting effects on other infections like hepatitis B, C, tuberculosis, and others. And of course, risk communication to the general public about infection prevention and control does need to continue across all levels to make sure that the public is with us, because without that, you cannot really have success. So I'll stop here, and I'm very grateful to all of you for your patient listening. Thank you very much.
Thank you, Dr. Sultan, for a very thorough presentation of some of the additional capacity that can be brought to bear for hepatitis elimination as a consequence of the response to the COVID-19 pandemic. And we'll be talking more about Pakistan in our discussion with Dr. Huma Qureshi joining for our time together shortly. Now let's hear from Dr. Jag Chatwal, who's the assistant professor at Harvard Medical School and the associate director at the Massachusetts General Hospital in Boston. Jag's done remarkable work in modeling the health cost effectiveness and the health consequences of hepatitis. He's also developed a variety of publicly available tools to help policymakers develop policies for hepatitis prevention, care, and treatment leading to elimination. And we're going to be hearing about a few of the new tools that he's developed in the presentation, and then he'll be available for a discussion thereafter. So let's hear from Jag.
Greetings, everyone. I would like to thank the organizers for giving me an opportunity to talk about our tools on hepatitis C elimination. So as you know that the World Health Organization has set a goal to eliminate hepatitis C by 2030, and one of the targets is to diagnose 90% of the Hep C population. Therefore, the first step for us is to identify a cost-effective testing strategy. Unfortunately, one-size-fits-all approach does not work for Hep C testing because the prevalence can vary by jurisdictions. Also, differences in population characteristics and opportunities to engage in care can substantially vary from one place to another. Finally, the differences in budget and resources between different settings can also influence which Hep C testing pathway is used to detect cases. So as the cost of treatment has come down, the cost of screening now is the largest driver of Hep C elimination plan in most countries. Therefore, we should tailor the diagnostic strategies to each situation. And we should use a systematic and structured approach that is backed by organizations like the WHO to identify cost-effective diagnostic pathways. A few years back, we launched Hep C Calculator, an online tool in collaboration with the World Health Organization that evaluated the cost effectiveness of Hep C treatments. In most countries, we find that treatment is cost saving. And today we are launching a new addition to this tool, which is focusing on Hep C testing. The tool estimates the cost effectiveness of different testing pathways for a given country. The methodology is similar to what we had used in the past. There's a microsimulation model that simulates the natural history of disease for a given country based upon the epidemiology. Users can then look at the results for different pathway settings. Here is a screenshot of the tool. As a first step, users select a country, the population characteristics like number of people, the viremic rate, the target screening rate, the cost of DAAs, etc. And then users can select different testing pathways. They can create their own pathways, such as what is the first step for screening, what test is used for confirmation, is it, and what's the location, does the patient travel, or is the testing done on site? Then what kind of liver staging is there? Is it on site or patient needs to travel? What is the cost of travel or on site testing, etc. And then also it ends with, finally, how do we assess SVR at the end of the treatment? There's also an option of selecting default pathway options, and this is a screenshot, shows that 5 different pathway options that have been embedded for a given country. So after selecting the pathways, the results can tell us what is the total cost that includes cost of testing, the treatment, and sequelae if Hep C is not treated for each pathway. We can look at the quality adjusted life years for a given pathway, the incremental cost effectiveness ratio, which tells us if the testing pathway is cost effective or cost saving, percentage of viremic patients diagnosed, the diagnostic cost per patient treated, and how many patients were treated eventually. For each pathway, we can also look at the clinical outcomes at a population level. For example, the figures below show per 10,000 people how many cases of decompensated cirrhosis will happen under no screening and for other pathways. And also the outcomes like hepatocellular carcinoma and liver-related deaths. So in this case, in this example, we found that pathway 1 is the most optimal pathway because it is the cost saving. It results in the maximum quality adjusted life years and also saves cost compared with other screening strategies. The existing tool does not allow us to inform if Hep C elimination is feasible and what would be the budget. Like questions like how many people need to be screened to reach the elimination target, how many patients need to be diagnosed and treated, which testing strategy should we use for a given setting, how much would it cost to eliminate Hep C. To inform some of these questions, we are developing a new tool called Hepatitis C Elimination Tool in collaboration with the Task Force for Global Health and Coalition for Global Hepatitis Elimination. So this tool will be informing questions like the feasibility and budget for different countries. So in this case, in summary, we are today launching a new publicly available online tool that can assist in making decisions on Hep C testing strategies in different settings. So this tool can inform the project managers and policy makers to make informed decisions that improve outcomes and also identify strategies that are either cost effective or cost saving. We are planning to add more countries in the tool to inform testing strategies. Please reach out to our collaborator Sonil Shilton at FIND. I'd like to acknowledge the support from FIND and National Science Foundation, my collaborators from FIND, Mass General Hospital, and CHIPMER. With that, I would like to thank you all for your attention.
Thank you, Jag. We'll be here. Jag will be joining our discussion in a moment, and we have a really great group put together to give us some updates regarding progress of some programs targeting hepatitis elimination in a variety of countries. A number of these have presented at IVHEM in the past, and it's good to get an update about, learn more about where they are now, and then looking ahead, what are some of the future steps planned to complete the journey toward their elimination goals. I think we'll start with hearing from Dr. Gagandeep Grover, who's the State Program Officer at the Department of Health and Family Welfare in Punjab, India. They've had a program in that state underway for several years, and so Dr. Grover, it's good to see you. Perhaps in a few minutes, since we only have a few minutes per country, if you just give a little bit of background briefly about the program for those who are not aware of it, and what have been some notable progress for the program, and then looking ahead, what's the remaining work to be done, please. Good to see you.
Thank you, John, and thank you all. And just apologies for the little glitch we had with the technical connections. In Punjab, in India, it's a northern state in India with a population of around 29 million. And we have started the program in 2016. It's now been more than 4 years with the program. When we started, actually, the prevalence and incidence of Hep C was not known, but it was known that incidence of Hep C is more in population of Punjab as far as data of blood banks and blood donation and volunteers were concerned. So it's been 4 years. We started in a decentralized manner in 25 hospitals. Now we have expanded to now 62 centers where we are providing the treatment of Hep C. And this year, when we were struggling with COVID situation and the patients were not able to come to our hospitals, we have designated all the antiretroviral therapy centers where the HIV positive patients, HRGs, are coming. They have been designated as treatment centers. OST sites where IVDUs are coming, they have been designated as treatment centers. And we have expanded the program to 9 central prisons of the state where all the HRGs are being screened and put on treatment. Until now, we have screened almost 180,000 persons in the state, and we have put approximately 90,000 persons on treatment of Hep C with approximately a SVR of 92.8%, roughly 93% is SVR. We saw a little dip in the cases during COVID, but we have bounced back and we are getting a monthly enrollment of approximately 600 to 700 patients on treatment across 62 centers. So another what we have started with hepatitis B this year in Punjab, along with hepatitis C. All the HIV positive patients, PLHIVs, they are being screened for hepatitis B as well. And all those who are negative, they are being vaccinated with hepatitis B. And all the females who are coming for antenatal screening, it's mandatory testing of HIV, hepatitis B and C. So we are going to prepare a registry of all the persons for Hep C and have the screening extended to other things. Now we are going down to from district level to sub-district level, and if possible, by end of the next year, we'll be trying to cover up our community health centers for screening and management of Hep C. Thank you.
That's great. What's been the reception among healthcare providers and the public to the program?
We got a very good response in the public. They are coming on their own. It is not active surveillance going on. We are not going to the community. We are just spreading the awareness through our different channels, and the people are coming on their own. On the other hand, I'll just tell you, John, the private sector has got a dip in their clientage after the launch of the government program, because when we started in 2016, the viral load test was being paid by the patient. The cost was around $29, which after a few tenders came down to less than $12. Now everything from baseline test, viral load to the medicine is being borne by the government of Punjab, and the patient is giving everything free of cost. From the baseline test, viral load, and complete treatment with SVR that is free of cost. So that's a good for the patients and they're coming.
Absolutely, thank you. I think we'll drop down on the list on our program to hear from Iceland and Raketer Friedrichsdottir to give us an update about the program in Iceland, which was one of the very first countries in the world to commit to hepatitis C elimination.
Thank you, John. My name is Ragnhildur, go by Heidi. I'm the project manager for the Track Hep C program in Iceland. This is a program that started in 2016 and was initially planned for 3 years. We ran this program and run this program as a multidisciplinary team approach where liver hepatology, infectious diseases and addiction medicine work together in offering every PCR positive individual in Iceland treatment with DAAs. We have been successful in creating a program that can accommodate a lot of patients and reach a lot of patients. And we do this both out of our clinics and especially when focusing on people who inject drugs and people in incarceration. We use outreach and we build collaborations with every possible service provider that comes in contact with our patient population. So we are now in an extension phase, but after the 3 years, we believe we have reached the WHO service coverage targets so that we have diagnosed 90% of those infected and treated 90%. But we are still working towards seeing if that will translate into a drop in incidence. We are still seeing new infections and quite a lot of reinfections. So the work is still ongoing and continuing, offering every patient that is diagnosed treatment and retreatment as many times as they need.
No, that's amazing. You made, if I recall your previous publication, there was about 1,000 to 1,200 drug users. Is that about right? Is that what you mentioned? And how many of those have been treated? I just want to make
No, that's an overestimate. We don't believe we have that many active drug users. Okay. So the Hep C prevalence in Iceland when we started was estimated as 0.3% of the population. So that would translate to 800 to 1,000 patients. Active drug users have been estimated around 400 in the population. Yeah.
So you feel like you've
and we have the prevalence of Hep C within our population of people who inject drugs has been around 40% before we started. That dropped by 80% during the first 3 years. So we definitely have been able to reach that population. But because, you know, hepatitis C, you can get reinfected if you continue to use drugs. So for each PCR positive patient out there still injecting, the risk is it can be transmitted. So they continue to be our focus.
Absolutely. Yes. Thank you. Let's turn to the another national program, Egypt, and hear from our colleague, Dr. Manal El Sayed, about the status of the Egyptian program, which has been profiled in a fairly recent New England Journal article from our, Manal, please give us an update and what's the work remaining for the Egyptian program overall?
Well, thanks, John. As you know, that Egypt had one of the biggest programs worldwide, and we managed to test over 50 million adults and so far more than 9 million children in less than 1 year. The COVID, of course, stopped the screening program in schools, and this was actually my baby program. And I think we're returning back very slowly, but with the second wave, I think it will be delayed a little bit. I think what's remaining for our program, that would be decreasing or proving that we decrease the mortality from liver disease according to the WHO targets to less than 65%. I think that's maybe one thing we need, and the incidence as well. We have to prove that the incidence has dropped particularly in populations that are high risk. I'm still seeing a small population of children who are getting infected, like those receiving cancer chemotherapy It's much less so for the multi-transfused. The incidence dropped dramatically with this large program that started in 2006, in addition to awareness. I think one of the opportunities we're having from COVID is that infection control now is not going to be a great problem like it used to be, because everybody's aware about infection control, both the healthcare providers and the public as well. The public are very much aware about infection control, and they know and understand that this is one of the key, plays a key role in transmission of infections, whether it's hepatitis or other infections. So I think awareness of the population as well as the health providers about infection control, that's injection safety. This is another thing. I think by this year, they would have launched the safety engineered devices. It was delayed because of the COVID. I think by next year, they're replacing all big hospitals' needles to the safety engineered devices. And I think that's something that's really important. Harm reduction, that's one of the things that we are still lacking. And I think this needs political will as much as political advocacy and stakeholders' engagement within the population that resulted in this huge program. I think it's important that we push with the civil society towards harm reduction. This is something that we are really lacking in the population who are using drugs. We have a nice study that we're going to publish soon looking at this population. They were treated, they were not stigmatized, they were treated within the national program. However, the prevalence is very high, the risk of reinfection is high, and some of them are co-infected with HIV as well as hepatitis B. So I think this population should be our focus. The PRISM program stopped because of the COVID temporarily, but we will go back to the PRISM program again. I think this is also very important. The refugee program also was halted temporarily, and I think it's going to go back, and the refugees are treated like the nationals exactly. They're integrated within the national program. So there are a few things remaining. I think we need to strengthen our surveillance, particularly for the high-risk population groups, and work on these specific groups and prove that we decrease the incidence and mortality.
Great, thank you. Quick follow-up about the COVID-19 response. Do you think the sort of the infrastructure that was put in place for hepatitis C, the treatment centers or the testing or the information systems helped Egypt respond to the COVID-19 pandemic?
Definitely, because we use the same exact systems of whether the infrastructure, the networking system, the database, the same similar database, all the systems that we used in the hepatitis was immediately used in the COVID-19 response. And I think that shortened the time to the response of the government. In addition, if I'm speaking also about the education, because we were already introducing the tele-education, and people were resisting, the population was very resistant to this kind of education. And it was enforced on the public last year, and they gave every student a tablet to use at home. So that was really great, because they used this during the COVID-19, and all the parents were very happy and very convinced this is the right way to go for education. So the same thing goes for the education, not only for hepatitis. And we used all those who were trained, the healthcare providers who were trained for the hepatitis C programs. Those are the same ones who are going to the isolation hospitals, those specialists who are treating patients with COVID-19. So I think their response was very rapid. They were highly trained. I think the capacity building we've done with the hepatitis, I think assisted the country a lot to respond to the COVID-19. I think any future infectious disease, we have all the tools that will help us to respond very rapidly.
Great. I've also heard that from Georgia. I don't know if others in the discussion today have any of those kind of experiences to share. I think one of the secondary benefits of a disease elimination program, when you look at the history of disease elimination, is a stronger health system, because you're improving the health system along the way. And I think this examples of how hepatitis elimination in Egypt improves pandemic preparedness is an excellent example of that. And perhaps that's happened elsewhere. I think we could hear more about. The other aspect quickly about Egypt is that the last 10 or 20% of the population to be found is often the most challenging versus the first 10 or 20%. And I think hepatitis C elimination program for Egypt has been truly one of the greatest accomplishments in public health, certainly in this century. It's great to hear that the program's going to be getting back on track after we deal with COVID-19.
Yeah.
Is that what I heard correctly?
Yes, actually, the program was running during the COVID-19. It didn't stop. The capacity was less. The number of shifts for doctors was less. We had to close some of the centers because some of those doctors were had to go and work in the isolation hospitals. But the program was running. It was a little bit slower, but it was running and ongoing.
That's great.
It never stopped.
Okay, good. That's good to hear. That's great. Resiliency in the health system. And then Huma, if you're on, Dr. Sultan cannot be here for the discussion, but you're a leader of the Pakistan Hepatitis C Elimination Program. You may want to make some general remarks to add on any updates from Dr. Sultan's presentation, but we got a particular specific question about his presentation regarding the cost of virologic testing for hepatitis. So, are you using laboratory-based PCR? Or are you using point-of-care PCR? Perhaps both. And what is the cost of the PCR testing that you've been able to obtain in Pakistan?
So thank you, John. Yeah, because the program is still not yet launched. It is to be launched in the next quarter. It got delayed because of the COVID. Our plan is that we will use the already available PCR machines, which are already there at the tertiary care and at the district level sites. We have one province and some sites which are difficult to access because of the distances and the populations. So we are planning that maybe for that province and some districts we'll use the gene expert, because fortunately we have the gene expert machine at every district headquarter hospital. So that they are the property of the TB program, but they're there. So we are going to use these machines, procure the cartridge, and use these machines for the difficult to access population and areas. But for the general population, it would be that the screening would be done at the basic health unit, and those who are found anti-HCV positive, their blood would be taken, and the blood will move through a courier. So the courier company would take the blood to the central lab, and the central lab will then do it as per standards. So that's what the plan is. But let's see, and the cost obviously is because we would be using either a Roche or a Abbott machines. So the cost would be obviously it's still under negotiations, but that's what we plan to do. Thank you.
Very good. Thank you, Huma. And Jag, I know you've done some modeling around the best approach for hepatitis C testing in Pakistan. That's been published. Is that similar type of output to the model that you just presented a few minutes ago, or how? Just to just point of.
Yes. Yeah, thanks, John. So the tool that we are launching today, it's the Hep C testing calculator, which provides the cost of, it tells which strategy is the cost-effective strategy for a given setting, depending upon the prevalence, access to the test, either it's lab-based or a point of care, or patients need to travel. So for a given setting, it tells you the optimal option. But the tool does not tell how much do we need to scale up at a national level to eliminate hepatitis C, and what would be the cost of Hep C elimination. So that's the distinction. The work we have done in the past for Pakistan was about informing Hep C elimination. How many people do we need to screen at a population level? How many people need testing and treatment to reach the targets? So that was one key distinction between the tool that we're launching today and the work we had done previously. Now also that we were developing, as you know, that with the task force and coalition for global hepatitis elimination, the new project which will inform questions on the feasibility of elimination, what countries need to do at a national level to reach the targets, and also the cost of achieving that target. And what is the best strategy, or what is the cheapest or the fastest strategy that can be used to reach the targets in a given setting?
Absolutely. We hope to launch that in the next month or so after the first of the year. So it's a nice complement to this array of models that you have available now. I think the challenge now is for us to, help countries, connect with you and others and these models to actually put these models into play so that the policy development and program planning can advance. Do you have some good examples over and above Pakistan of some countries that you are already beginning to work with or have in the past? Okay.
I'm sorry, what's the question? Sorry, I missed the last word.
Do you have some examples of some countries that have used some of the tools that you've developed up to this point?
Yes, so we have a variety of tools. The first tool we launched with the WHO, it has 28 countries. The ones that WHO identified as would cover 70% of the disease burden. And the new tool that we launched today, it has 4 countries, including Pakistan, India, and Georgia. And then as we work more on the new tools, we would like to collaborate with more countries, and we'll have that information available, the contact persons, what information we need from each country, so that we can expand the tool, inform as many countries as possible with this infrastructure in place.
Great, thank you. Heidi, cycling back to you you mentioned a fairly high rate of reinfection. Do you have an estimate of what that is? And what's the level of access to harm reduction for active drug users, particularly, the exchange rate of needle and syringe exchange, access needle, clean needles and other injection equipment, and to a drug treatment, and do you have a particular problem because some of the drugs, such as amphetamines, used in the country really are not amenable to drug treatment programs?
So harm reduction has been greatly intensified in Iceland, partly through our program, but also because of just a shift in the paradigm here in Iceland that harm reduction is necessary and should be a part of the services we provide for people on the margin. So the needle syringe coverage in Iceland is pretty high. What happens here, and the access to drug treatment is also very good. We are collaborating with the National Addiction Treatment Center that treats the majority of people with addiction problems in Iceland. And it's easy access, and everyone gets access. We do have a waiting list, but everybody does get access to addiction treatment that needs it. The drug problem in Iceland is primarily stimulants, and we have a prescription problem with methylphenidate, and so our most sick individuals are injecting very frequently. They use methylphenidate and are injecting maybe 10 to 12 times a day. So just the sheer volume of needles and syringes and just the level of risk of getting reinfected is so high. So that's part of the problem that we're dealing with.
Yeah. No, thank you. I can understand why that is a problem. I guess lastly, Dr. Grover, before we end this session, I know the national government is developing an elimination plan, and I've heard that perhaps there'll be a second state program in Uttar Pradesh. Please update me on the national planning and the possibility of another state-based program.
John, India has already launched the national program in 2018. They have already done their plan for elimination. Still, many states, they have to yet pick up. Haryana is doing good. Maharashtra state has started their program. They're working well. I'm in touch with them. In UP, they're working well. The data is still developing, and the portals, they are collecting the data, and I think by end of this year, the country will be able to showcase the person's screen data will be little more authentic, not 100%, but little more authentic. Even even we want to collaborate, like the other countries are also mentioning IVDUs. It's an issue in Punjab as well. Drug issues are there. We are still collaborating with that division so that we can do harm reduction and strengthen that activity for hepatitis C prevention in Punjab.
Great, thank you so much. I want to thank all of the discussants and presenters on the session today. It really was a wealth of information. Please follow up with continued conversations in the chat and also with these individuals directly. But the whole idea here is to build a community of practice for hepatitis elimination through discussions such as this. So thank you again. I think we'll be taking a break and then we'll be moving on to the next session. Thanks again.
Thank you.
Thank you very much.